Eric Lucas, my little cousin that's on his way to USC, is up next. So, Eric, come on and get it.
Well, we're sorry for that confusion, but I hope I'm a close second to Ms. Jakivia. Again, she could not make it today, but my name is Eric Lucas. I'm currently a medical student at the University of Mississippi Medical Center, and I have the pleasure to introduce to you Ms. Amy Swanson. Ms. Amy Swanson is a healthcare executive with over 20 plus years of experience. She currently serves at the Certified Community Behavioral Health Center as the co-director and also the 988 State Director for the Department of Mississippi Department of Mental Health. She is nationally recognized as a thought leader who advocates for the advancement of underrepresented groups. Today, she will be addressing maternal health issues and trauma through community-based programs and partnerships. Can we give a round of applause to Ms. Amy Swanson?
Thank you. All right, so I'm much shorter than Dr. Sheffield. This is not fair because I can't see the screen, I'm so short. So I may have to kind of lean this way. Good afternoon, everybody, and thank you so much to the Glenn Foundation for their great work. You spent your 365 days really well, and I would like to encourage everybody to give them a round of applause because this is amazing. What a thoughtful agenda and presentation, and I will try not to mess it up, okay? So we'll go from there. So one of the benefits you have of being the last person is that you get to kind of thread through some of the themes that you've heard today and relate them to what we are doing here in Mississippi around maternal health issues and trauma and community-based partnerships, right? So we still have a long way to go. And I think Dr. Hancock said it earlier, start on a journey with me. And I'm going to have you start on a journey with me. And it's going to start with data that you may, not really want to see. And I don't have the clicker. Oh, here it is. But stay with me because we are seeing some good community supports and programs. And we heard a lot today about how those are so, so critical. And I'm going to encourage everyone in the room to meet your community mental health center partners. There's many in the room today, and not be strangers, so we'll get to that. So there's 3 goals for today. One is to provide some general gaps around maternal and child health trauma, and I'm going to focus on substance use disorders. We've talked a lot about mental health today, but I also want to kind of bring in the substance abuse disorders. We'll talk about the new Certified Community Behavioral Health model that we are advancing here in the state of Mississippi. I'm really excited about it. It's going to address some of the very barriers that we talked about today. And then finally, I'd like to share some resources on crisis. And one of those is 988. You heard Eric introduce me earlier, and what is this 988? And I've actually done a little mini study today, and I have not met one person who knew what it was. So I'm going to spend a couple minutes walking you through it because I ask every single one of you to write it down, keep it with you, and use it. It's a fantastic resource. Okay, so the U.S., as you may or may not know, has increased significant increases in births affected by substance use disorders. Opioid-affected births have quadrupled. Methamphetamine births, again, increased over the last decade. Opioid use in pregnancy increases, and we heard a little bit about that today from the other presenters. And SUDs are still among the groups, one of the largest increases among women in rural communities, low-income communities, and with Medicaid coverage. Women of color have greater risk for life-threatening health issues. We've talked a lot about that today. And these substance abuse-affected deliveries can increase healthcare costs dramatically. Mississippi, and here you can see our statistics here, we fall at about 30 in the states. So right, kind of a little bit higher than the middle, but as you can see, we still rank up there. Inpatient deliveries with the mention of substance abuse in the discharge record. So if you start to look at what Mississippi's count is, we have an average rate that are being reported at about 24% in those records. Nearly 1 out of every 4 childbirths is affected with substance use. And on average, sadly, of the women needing substance abuse treatment in Mississippi, only 26% were served. So we as an agency have taken on this challenge and are working very hard, and I'll walk you through some of the resources here in the state. We can benefit from doing more. I'm not going to stand up here as a state official and say we're doing everything right. We got it all figured out, because clearly we do not, because the numbers haven't changed dramatically, right? But what we are starting to see is these investments are making some improvement. Some of these are simply around more education, training, and awareness. I cannot stress this enough. We just recently completed over 1,900 Mississippians. Of those, 64% of the respondents were actually individuals with lived experience. And the number one gap and barrier we have in Mississippi is awareness. People don't know what the services are, where they can find them, and they also don't understand the illnesses. They don't understand the conditions. We absolutely have to expand early detection and screenings. This is a must. We can't just have this happen when someone comes in and says, I have a problem. And I believe Dr. Shelfed said that earlier, and Dr. Hancock both, in terms of getting out there. We need a lot more collaboration. And I know I'm walking away with business cards of everybody that was on the panel today. We can't leave this room or any room we go to without meeting a few people. And forgive me, but you can meet in person and grab a cup of coffee these days, or just grab a Zoom chat, whatever. But don't leave without meeting someone else from a different arena, right? If we don't bridge the gap between the physical and behavioral health systems, we are never going to get out of this. So we have to have that collaboration. And then we have to expand treatment services and quality-based treatment services. So how is Mississippi addressing many of these challenges? And as you can see here, we have expanded our statewide residential bed capacity for parents and pregnant women with dependent children SUD programs, all right? So there's more increased beds. And you can see where some of those sites are on the map that you see in front of you. And you'll also see on the map, you'll see a bunch of numbers there. I'm going to call your attention to those numbers. Those are community mental health center regions. How many are some of our community mental health center partners here? Can you stand up for me, please? Thank you. Okay, stay standing. Did y'all see this? Okay, you're challenged. I'm challenging you. Go get their card. Go give them your number. Meet them. These are people that I have heard today, thank you guys so much, that you guys have not connected resources with, right? They're in our communities. Get to know them. Get to work with them if you don't already. And that's what those numbers represent. So we have also brokered a partnership with a marketing firm to really do some more public awareness campaign building, right? You can't do this without that paid advertising and social media contacts for pregnant women, parenting, and postpartum. So you'll see that theme there. It's not just pregnant women, it's parenting women, right? So it's that full continuum. We've done significant service expansions with Region 6 and Region 12, and they are doing amazing, amazing work. So what is the second piece that we were asked to kind of talk about today, which is, okay, what is Mississippi going to do to transform its community behavioral health system? What are we going to do to ensure we have more access? So the path that we've chosen is to implement what are known as certified community behavioral health clinics. These clinics and the value that they have for Mississippi is they will improve access to delivery of service. They will offer more competitive wages. Again, reoccurring theme we hear about workforce. It will address gaps and barriers to care, including same-day access to service, no wrong door. You don't have an insurance card, you cannot be turned away. Okay, did you all hear that? Don't have an insurance card, you cannot be turned away from a CCPHC. So that's what we need to move towards. And establish sustainable funding for our system. The payment structure with this program, this federal demonstration, will allow our community mental health centers to have a flexible daily rate model where you bundle services. And so that gives the practitioners, right, the ability to develop a treatment plan, a crisis plan around what the consumer needs, not what the claims and encounter system need, right? So how do we get paid? So it's a different structure. And it will engage additional stakeholders in that continuum of care. One of the main requirements of the CCBHC model, and Mississippi actually is using the federal guidelines, but we added additional guidelines for our state, is we expanded the number of mandatory partners that community mental health centers will need to have in their CCBHC. Many of your organizations are on that list because we have to have expanded partnerships. And I'm not just talking about the typical MOUs that are out there, right? Those memorandums of understanding that say, we're gonna work together. We're gonna be really good partners. Nope, these have more meat on the bones. They are true care coordination partnership agreements. So it is going to be an agreement about how we're gonna serve those shared consumers together, right? How are you going to work with them? How are we going to work with them? And more importantly, how are we going to collectively work to get better outcomes? So that is the value for Mississippi. So what is this CCBHC? How many of you have heard of them? Oh, so we do have some awareness. Okay. So we have about 7 of them out of our 11 community mental health centers here in Mississippi, but they are an integrated approach. So it is bringing behavioral health and physical health screening and some outpatient services under one roof so that when someone comes in for a therapy visit, you can check their blood pressure, right? You can see, oh, something's not really going well here. Can we make sure that you get to your doctor, right, for those follow-up visits? It offers a full array of services that I'm going to cover on the next slide. So it ensures that no matter which CCBHC door you're going in, you don't have to second guess what services are going to be available under that roof. There is consistency in the scope of services delivered. And then finally, there are those real collaborative partnerships with community-based organizations around serving those shared members together. And I can't think of a better population than pregnant women, and parenting women. So these are the 9 required services under the model. So you'll see there's crisis, screening diagnosis, psychiatric rehab services, peer and family supports, person and centered family care planning, outpatient services, and then outpatient primary care screening and monitoring. It's not it's not putting a doctor's office there necessarily. It's making sure that there's screening there and monitoring of those conditions, right, as you're working with them. And so that is the CCBHC scope of service. So no matter what door, remember, do you walk in, will you get those services? So no longer do you have to go, oh, I think that agency does peer support. Nope, they're all going to be consistent. So there is some real early results across the country for those areas where we've implemented CCBHCs. The time to receive services has dramatically decreased. So we're getting people into services. They're getting in with one week and within treatment planning within 10 days. The next slide is my favorite though. This is through the Medicaid demonstration showing you the improved access to care. And what I always like to remind people is the care is not done in the 4 walls of a building. Come on, that's not the way people live and work and play. They're out in the community, they're in the home, and so these services where they've put a CCBHC in place, look at that, 78% increase in services in a consumer's home. Schools, I mean, makes so much sense, right? And we're doing some of this now. So y'all might be looking at me going, we do all this now. We do. It spatters though, right? And this is about bringing a level of consistency and more importantly, quality and accountability for those results and those outcomes. Additionally, we have new services that come online, right? So this model allows us to provide new things that are not necessarily being done and consistently across each of the agencies. So you can see there's dramatic improvement in those service. One of the biggest areas that is, I don't want to call it's a bit more of the nerdy side of the CCBHC model, but I'm a quality data nerd, so I'll sign up for it. But this is where I wanted to make sure y'all were aware. The CCBHC model requires any of the entities to have a standard set of quality measures. And when we worked with our partners at the Division of Medicaid, we said, hey, look, there's federal requirements. We can do the minimum. But what's the population need here? What are our population health needs? Number one on the list, pregnant women, young children. So what happens when you put in quality measures? And then you also, we're going to incentivize those measures. So we're going to incentivize providers who see more kids, who see more pregnant moms. What happens to your program model when that change occurs? Flips it upside down, right? Your service delivery model changes because you're changing the way that you're measuring things, incentivizing people, and then tracking that accountability. So you're not just paying to do more of the same, you're really challenging your system to go beyond. And I'm really excited. Mississippi chose postpartum measures, additional postpartum measures. We are one of the only states in the country that may be doing this. It's very exciting. And secondarily, we've also chosen some early childhood measures, right? So families are coming in to community mental health centers and to providers' offices with their children. And we should be thinking about how we can serve them collectively, because they don't get separated when they go home, and then everybody, it's care that happens together. So we're hoping that we can expand that. What it'll mean is providers will be incentivized for delivering results on those measures. So some providers have said, we don't serve that population. We don't serve kids under age 3. Well, guess what? You got measures now. We're going to provide you some incentives. We're going to also provide resources for evidence-based practices, because we're not going to just deploy new non-evidence-based practices. We are going to use evidence-based models, and we'll incentivize you for it. Additionally, we have decided with our partners, the Division of Medicaid, that under the financing model, we are also going to incentivize you hiring more licensed professionals. Now, the model, you heard me talk about it earlier, it's financed based on a very different approach. And so it's going to allow those centers to anticipate the additional cost it's going to be to pay the providers to get the licensed providers into our CCBHCs. So there's some professional development pathways. So the way the system works is that there'll be quality measures and reporting and financing, right, that pulls it all together, that helps build and stabilize our system. And you'll see here that each CCBHC collects and reports on data. They're going to have to develop quality improvement plans. And so this is not really just your average, I'm going to do something. It is going to be very measured. So we do have 7 SAMHSA CCBHC grantees in the state of Mississippi. You may recognize some of these if you're from our state. They are wonderful. Our community mental health centers are just, they're the best. And so you can see some of those partners there. And obviously we want to make sure that they're available everywhere. So the other piece that we were asked to talk about was the crisis system here in Mississippi. So how many of you have heard of 988? You can keep your hand up. How many of you thought it was in Mississippi, or was available in Mississippi? Did you know? Okay, we've got a lot of work to do. There are too many people across the country that are struggling with suicidal thoughts. They're challenged. They need some help, right? Most notably, they will call 911, and as they should. in the case of an emergency, right? But 988 was launched about 3 years ago nationally. And then it was launched here in the state of Mississippi. And we have 2 crisis centers. We're fielding thousands and thousands of calls every month. It's a resource for people that you know who need some help to call, to talk to somebody, rather than head to, calling 911 and, or calling the hospital. It's trying to sort of be that bridge for people. It is not meant to replace medical professionals. It is not meant to replace sheriffs and police. No. Fire, EMS, no. But it is there for those times when somebody just might need someone to talk to, right? There's a chat and text that we've launched in the state of Mississippi. And that has obviously been very popular with our young people. Our partners at Open Up Mississippi, which is a youth group here in the state. I don't know if some of you know about it, but they've actually been working with our crisis counselors. Talk to them about how do you use this chat and text function. It's like learning a whole new language. They gave us a cheat sheet, but it's an available resource. It's free. It's anonymous. Nobody's going to track you. Now, if you want help, if you want to be connected to your community mental health center or another provider, they'll do that, but only with your permission. So I urge you, anyone you're working with, make sure they know 988 is available. I think about some of the stories we heard earlier today, and I was thinking about that young man, and that just broke my heart, right? But maybe if 988 had been written on the fridge, maybe, I don't know, maybe somebody would call, maybe have a listening ear, someone to hear, and a trained professional who's available to do that. We have peer support specialists at each of our centers working with these individuals. So, and they are licensed. And I want to tell you something, because everybody's always like, and I heard it multiple times today, Mississippi's at the bottom. Mississippi actually has our crisis system, our 988, are the 2 most recognized in the country, high functioning. We have the highest answer rate. So come on, it's great. Come on. I know, you're like, lady, get off the stand. I want to finish my cookie and go home, but I'm really proud of the fact that our state has that. So, and it is important to know what it is and what it isn't. It is not EMS. Now, we do have protocols, so if you do call one of the centers and it does, in fact, appear to be an emergency that they need fire or police, they will make those transfers, and we have those protocols. And they have connections at each one of the community mental health centers. So that's a little bit about what's happening here in Mississippi, and what I was asked to come and talk about today, and I don't know if there's any questions. But it is tough being the last one too, because I can see I'm between you and leaving. Yeah, just what every bureaucrat wants, right? To be that person. So.
Well, I would like to say.
Oh, yes, ma'am.
Is it on now? Oh, it's on now.
The boss
I
speaks.
Thank you. No, Amy, I just want to, first of all, just thank you for the work that you've been doing for the last year. The Glenn Family Foundation actually has been a community partner in this work, partnering with the Department of Mental Health and looking at the CCBHC model and really trying to engage and bring populations like you guys together with all of the events that we have to be able to educate people around that. First of all, the change model and the services that are available. I really appreciate the fact that all of the services are coming around from a wraparound perspective. And then it's being in the EHR system, it makes it a sustainable process, and that everyone has the same thing that's from the triage process or the entry process, or however that's done. But wanted to thank you so much for your partnership, and we're always available for any other partnerships that are available.
I know. She hit me up earlier.
Thank you much.
No, we've really appreciated it. One of the things we've studied over the last, and it's actually only been 9 months, Helen, I can't believe it. But we had to rapidly put together a big federal demonstration application. But one thing that we did different than some of our partners across the country is we intentionally funded the Glenn Foundation to help us study, and we also funded Life Help, fantastic community mental health center in the Delta. They just, they do such good work. I think some people are here from Life Help. They are like our heroes. They're great, and we have Pine Belt here. So, one of the things we did was we studied how to really have meaningful client and family engagement. What we learned was during our initial audit was that many of our community mental health centers had advisory committees, right? But they didn't have a structure or a governing capacity that you actually have to have with the CCBHC model. So the CCBHC model, to have the stakeholder engagement piece, you have to do it to fidelity. It's kind of like an evidence-based practice in many ways. But we didn't have a toolkit for that. We didn't have a way to figure out, if you're a provider and you want to be a CCBHC, how do you have to build your consumer advisory council, right? How do you do that work? And so we leveraged our relationship with the Glenn Foundation and our partners at Life Help, and we've studied that, and we've put together a practical guide for providers. It'll be released, I'm hoping at the beginning of May, and it's going through all that proofing process, right? That takes forever. But, and that'll be a toolkit for providers to use to develop their own governance structure to have meaningful client engagement, right? So we're not finding out that we developed this form and we developed this intake process and it really works great until the clients come in and nothing about it worked. Nothing, right? It wasn't consumer friendly, it wasn't culturally competent, there was nothing about it that worked. And so we'll hopefully get ahead of that a lot earlier, and we have really, really appreciated the Glenn Foundation.
Thank you so much, Ms. Swanson.
I'm done?
Oh, no, you're not done yet?
Oh.
Well, we will entertain questions. If you guys have any, please come to the mics at my left and right.
No one's gonna come.
But I really love that you addressed bridging the gap between mental health and physical health. And I challenge all of our clinicians and our specialists in the mental health field to truly bridge that gap. But if there's no questions, I do pose one.
Oh, okay.
You did address about substance use disorders. And just like any other disease, whether it's a medical or mental illness, this must be addressed. But how do we combat or address the stigma of substance use disorder that is placed on mothers when in clinical healthcare facilities, and honestly limits them from receiving the proper treatment that you guys provide?
Yeah, that's a great question. And through the expanded bed capacity and we've established some additional partnerships through the agency with the OBGYN community and around really starting to how do we help bridge that gap. Additionally, you saw that we are doing public awareness and activity building. We're going to have to break the stigma that way as well and take the fear out. But it much like implicit bias, there is no single antidote for it. It's going to be a continuous journey, right, for us to try to figure out how we do this better as society. I mean, we can't, there's no quick fix. So education, awareness, and obviously continuing to fund programs and to require those programs to actually follow guidelines that ensure that doesn't happen.
Thank you so much. And to follow up with that, you just kind of mentioned, leading into the next question, with the legal battles that we face against women's health in the state around the country, bless you, what would the state of Mississippi need to reach majority, if not all, pregnant women suffering from substance use disorder?
So, in my capacity, I really am not in the position to really talk about that, and forgive me, that would be if I were looking at my colleague at the Division of Medicaid, right? There's some solutions around the country where states have really bridged this gap for pregnant women through Medicaid expansion, presumptive eligibility for Medicaid. That can be a powerful tool. So there are some tools, and my old friend Wesley, we worked together years and years ago on all these mechanisms. But quite simply, we have to create a culture, and I can say this. there's no wrong door. Have conversations, have communications. You know, I find a lot of times, even in talking with consumers out there, and so many of them say, I'm not eligible for that service, I don't. Most of the time, they don't know where to find it, and they don't have the help to actually apply for things. And so if I could, you know, ask, make sure you have application assistance individuals in your agencies that know how to navigate the waters. Because a little bit of help is something, right? A little bit can go a long way for someone and give them just that little bit of hope, that joy that they can accomplish something. But there are some public policy changes that states can make to do that. That was a loaded question. Thank you, Eric.
My apologies. Well, if there's no further questions, let's give a round of applause to Ms. Swanson.